Hello, everyone. Welcome to our Healthcare Delivery and Implementation Science Center speaker series. Our topic for today is patient and stakeholder engagement in implementation research. Our next slide. I'm Anita Mr. Hebert. I am director of our Healthcare Delivery and Implementation Science Center here at Cleveland Clinic, and also our site lead for our participation in the Clinical and Translational Science Collaborative of Northern Ohio. We are very excited today to have as our guest speaker, Dr. Michelle Eakin, who is the co-director at the Johns Hopkins Behavior and Implementation Research Center and a professor of medicine in the Division of Pulmonary and Critical Care Medicine at Johns Hopkins University. Welcome, Dr. Eakin. Before we get started, I'm just going to go over the agenda. Really is we will have Dr. Eakin speak, and then we'll have some question and answer period at the end. And I'll give you instructions on how to put those questions in a moment. We will try to end on time right at 1 o'clock. So our learning objectives today are first to discuss meaningful patient engagement and frameworks for engagement and implementation research. Number two, to describe various components of engaging patients and other relevant stakeholders in research. And then to discuss some case examples of successful patient and stakeholder engagement in an implementation research project. And I know that's very important to a lot of us because we often try to appropriately engage patients and stakeholders in our work. And Dr. Eakin has been successful at this, and we really want to hear from her about this. And get some tips on how to do this better. So the next slide, just finally, some announcements. Our Cleveland Clinic Center for Continuing Education designates this internet live activity for a maximum of 1 AMA Category 1 credit, and physicians should only claim the credit commensurate with the extent of their participation. And then also the Cleveland Clinic Center for Continuing Education designates this internet live activity for a maximum of 1 ANCC contact hours as well. The credit claiming will open on April 28th, and you'll be notified by email with instructions to claim credit and to download a certificate of attendance. Questions throughout the session may be submitted through the course using the MS Teams Q&A feature. So please feel free to write questions in whenever you like, and then we will, if there's an appropriate break or at the end, we will try to get to as many as possible. This event today is being recorded and will be shared with everyone, the attendees, within 2 weeks following today's event. And we will have the syllabus in the chat. And we will just turn this over to Dr. Eakin now. Welcome again.
Well, thank you. I really appreciate the opportunity to present today. I'm excited to be here. I appreciate the wonderful introduction and to talk about some of the work and things that I've been doing around patient engagement and implementation science. So I have no commercial disclosures. I do have received funding from the NHLBI and PCORI for the work I'm going to talk about today. I'll just start with kind of, an idea around implementation science. Most of us here already know what it is, but, this really kind of came about with this idea that we were doing all this research and it wasn't really getting implemented into the clinical environments to really have an impact on patient outcomes and our public health. And so as we developed implementation science, it's sort of been groundbreaking in changing and thinking about our NIH translational spectrum. And many of us are very familiar with this spectrum with T1 to T2 work of bench to bedside and then bedside to clinic to identifying clinical efficacy. But as our science has evolved and our broader interest in actually improving clinical outcomes, we've now seen work from T3 moving it into community and into patient and population policy work for T4 implementation work of how do we actually get the evidence that we've identified into the practice to have the most impact. And along the way, we've had many different frameworks and models of implementation science, which I'm sure you've had wonderful speakers on. I will just speak on and point out the most common one that people refer to as the consolidated framework for implementation research. And this framework has been around for about 15 years now, and it really is seen as a meta framework in the fact that it is It evolved by taking all of the existing frameworks on implementation science and kind of consolidating it. It has been revised. We're now on CFR 2.0, which this illustration talks about. And I really think that, what I want to highlight on it is, as you can see, is it involves the outer setting, the setting in which we're working on, our inner setting, which is more often the clinical team we're working, and then the individual, which is both the deliverer, which is often the clinician or the clinical team, and the receiver, which we often think of as our patient. And all of those people kind of interact together to implement the intervention or innovation that we're studying. From that, we have different processes that are engaging to help increase uptake and implementation of the intervention. And we have just aspects related to the innovation. But what we kind of see here, and it's important to see, is that implementation is a team sport. David Chambers is one of the fathers of implementation science, says that all the time. The implementation process is a team sport, meaning that there are so many individuals with different perspectives and roles interacting to really bring about implementation. And within the CFR, we can look at this implementation process that involves creating a team, assessing needs, understanding the context that you're working in, planning, and then doing the work of actually implementing those strategies, monitoring and evaluating and iterating to optimize outcomes. And as we've seen this implementation science work, it really started primarily on working within the clinical teams. And actually, for a while, I would often be like, where's the patient in this? Where's the patient? Because they weren't actually in part of the original CFR. The patient wasn't there at all. And as we did the work, we realized very quickly that actually the patient was key to all of this. And we saw a really big focus in bringing in community and patient engagement with implementation science to have the biggest impact. And that if we were going to be implementing in a clinical context, we still needed to do all that partnering and teaming and assessing the needs within that clinical context. But the patients needed to be at that table, or the community needed to be in that table, in order to make sure that the innovation was acceptable to the patient, that it was something they were interested in, and that we had meaningful outcomes that was important to them. And that they really also became a major driver of implementation success. That if patients are coming and talking to their doctors and saying, hey, why don't I have access to this? The doctors are going to look into that more and more. Number one. Number two, we see if patients is really meaningful in advocating policy changes, and really, can be important to identifying and developing strategies to increase uptake of interventions. And so we really have come to realize that engagement and patient engagement can increase our implementation success, and really are now becoming a major part of our implementation science methods. One study that, was actually multiple studies in the early 2000s that really looked at the use of an implementation team, and found that using an implementation team increased intervention outcomes by from 14% to 80% in just 3 years' time. And so highlighting that having that partnership can really improve uptake and implementation, significantly by having everyone work together. And so from there, we really now begin to see that community engagement, patient engagement has become almost a core essential element of our implementation science methods. And why is this? Why do we need it? I talked about that patients can inform the uptake of the interventions. They can be advocates. They can be change strategies. They also have the decision to accept the intervention or not, and there. But really, overall, we know that stakeholder engagement is critical to really increase acceptability and create buy-in. Oftentimes, previously, implementation science was seen almost as a top-down approach. Evidence would be identified, the guidelines would be there, they would be rolled out and said, and this is what we should do. And that was, because the academics and the research says it, and then they would tell the clinicians that this is what we need to do, and the clinicians would tell the patients this is what you need to do. And obviously it creates a significant power imbalance. Over time, our ways of thinking have evolved on this. We now see that we get better outcomes by partnering, by making with shared decision making, patient-centered care, where the patients actually have a role and are very active in this process. And we really need to shift that power imbalance so that it is more equal. And by doing that, we can increase acceptability and buy-in. Patients believe in this, they want to try, they are a part of it, they're part of the decision making, they're more willing to and more apt to accept and increase it. I do a lot of work in adherence. This is medication adherence. We know that acceptability and buy-in is one of the biggest drivers of long-term medication adherence. If the patients believe that this medication is going to work for them, they're more likely to adhere to it over time. And so increasing that engagement can reduce that can address this power imbalance and increase adoption. In addition, we see stakeholder engagement in increasing our engagement with our providers. If we're implementing in a clinical health system that has a network of providers coming in, and we've had it happen, and I know many of us have had it happen of there's a new policy. This is what you're going to have to do. And it's often met with grumbling and frustration because they weren't involved in the design and the implementation, or even believe in this policy. We know if we want to increase adoption, we partner with all stakeholders. They have an input in the design. They understand the evidence supporting this new change. They have willingness to work on it and have a voice in the matter. We will have greater rates of adoption and success. So we go back that, as implementation science has been evolving as a field, I will say community engagement research has also been evolving as a field on its own. And we can look back into a lot of the work that was being done in community engagement outside of the implementation science frameworks and look at the work that they have done in terms of principles and necessary core competencies to really be an effective community and to really engage in meaningful community engagement. And these principles were actually developed by the Health and Human Services in 2011. And I don't think there's anything here that is not surprising, but I think it's important to highlight that these principles have to come first in our community engagement. We need to have clear goals and expectations of all stakeholders involved. We need to be knowledgeable. We need to know about what we're trying to implement. And we also need to probably take some time to learn from the community about their experiences, their past, their expectations. In that process of learning and gaining knowledge, we establish trust. We become respected partners as opposed to a top-down power imbalance. An important one that I think is in oftentimes something that we don't often think about, but it's important to recognize, is that the goal should be that the community is empowering themselves, that this is getting the community to move forward and engage, and they're autonomous and they have empowered, and they're it's not something that we get to just roll out and have them accept it. They have empowerment to be able to say yes or no and have that decision-making partnership and that decision-making power in order to be effective. Partnering and equal partnering here is necessary, which is really built on respecting the community. In addition, I think one that I often think about and it will come up is utilize the community assets. There's a lot of resources available in the community and they want to be included and used. As we've thought about a lot of different programs that use community health workers, I often try to partner with the community organizations that we're working with to identify their staff or our members as the community health workers. They have a knowledge of the community. They already know what they're working in. And it's utilizing the community assets and the community strengths and giving them growing into a strong partnership. This is a little hard for us academics, but we have to release control. That means some of the things that we do will be what's best for the community and not what's best for the science. And this is why oftentimes implementation science has, is more pragmatic, because we're not able to strictly control the environment to have optimal internal validity. We need to be adapted to the context and understanding what the community needs, which means that things aren't going to be as tightly controlled. Within implementation science, there's ways of tracking those adaptations, there's ways of measuring, and we can look at it. But we know at the end of the day, in order to maximize external validity, in order to meet the community context that's important, we're going to need to release control to be able to work with the group that we're trying to partner with. And then finally is be committed. I think over and all, the one message I have received, it was a community member that once said, the most important thing you can do, show up, volunteer, or, to do something, and then do it. That they have, as they've worked in partnerships with academics or health systems, they feel like sometimes they show up and they say they're going to do something and they don't follow through. Or if they are trying to implement something, they're not really doing the engagement and the pre-work. So it's important to kind of do all three of those stages. You need to show up and learn, engage, volunteer, and find ways of what are the action steps of each group, and then follow through and complete it to really be committed and show those good, strong community engagement principles. PCORI has put forward this engagement framework. You can find it online, where they've really, outlined what each one of these group foundation expectations are. And I'm putting it in here because a lot of the work I've done has been funded by PCORI, and so it kind of worked within this foundation. And I think it's a good framework to consider how we engage with the community. The first is making sure we have representative involvement. Do we have the right people in our advisory boards to really represent the communities and patient groups that we're working with? We want early and ongoing engagement. This often means before the grant has been written and before the grant has been funded. I will say that's always a little tricky because you're working in developing a patient advisory board before you even know you're going to get the funding. And that is often difficult because, we know what funding lines are, and that oftentimes it's not the first or second submission of the grant that's going to get funded. It may take a while, and that could actually extend into years to really move forward. And so I think how to navigate that is challenging. I'll talk about what we've done and to address that, but I do think it is important to really think about early involvement so they are informed at the proposal stage, and then making sure there's ongoing engagement throughout the study design, implementation, and evaluation piece so that they are active and members of this research team. There needs to be, PCORI likes to see dedicated funds for the engagement and partner compensation. They're important members of our team, and we should compensate them for their time. Building capacity to work as a team. So that might need some pre-planning work to really develop that team membership and that team group to particularly built on those community engagement principles I discussed. Meaningful inclusion of partners in decision-making, making sure that all parties agree with everything. And so some decisions may have to be compromises in order to meet the needs of all the stakeholders. And then ongoing review and assessment of engagement. They're constantly looking, how can we do better and how can we improve our engagement processes? There was a recent article published last year that actually did a systematic review of community engagement in implementation science. And I should say, I'm using the terms community and patient engagement interchangeably, depending on the context, but they're kind of the same, really working at the end users of whatever we're trying to implement. And they went in and they did a systematic review of almost 30 implementation projects and saw what kind of models or how were the patients engaged in the implementation process. They found, majority of them had some collaboration in the design where they were working like either involved in the shared decision making, they were a committee representation on a community advisory board or a national advisory council, and that some of them had the public as researchers or they were kind of members of the design team. And so it could range from like maybe quarterly community advisory boards where they're more advisory roles up to, a co-PI with lived experience. I mean, up to like a member of the design research team, up to even having co-PI as a person with lived experience talking about their disease management. Within that, that might be more one model. Within the design and conduct of the study, we saw a lot of engagement of the patients as consultants, where they were providing feedback on study information materials, interviews, survey design. They might be working with user testing if they're developing apps or interventions, or roundtable discussions and workshops, kind of, developing intervention mapping or focus groups to see how this implementation process would go. And then finally, at the end, having public engagement as using the public as implementers, whether they be community voice advocates, members of a community coalition, or an implementation team. So I think we can see different roles and models of which patients can be engaged in not just the conduct of the research, they can be involved in the design and the input and the evaluation, as well as actually being implementers themselves and having a role in the implementation process. And this kind of resulted in a continuum of engagement where you can see in the non-academic partner into the research versus the academic research partner output to the partners. So true partnership is where they're both equally giving input. Maybe where there's more consultation, outreach, and education, it's less input and it's more kind of one and done. You're either getting input from the non-academic partner to you, or you're giving outreach to them. And then you can see cooperation, collaboration, and partnership. Cooperation where there's maybe a board and they're providing consultation. Collaboration where there are more members of the team, and then partnerships where they're really working equally on the project together. From this, I feel like there's lots of different models of how we engage with communities. And one model that's become very increasingly popular is the co-creation of implementation plans or implementation strategies. It could also be co-creation of interventions. It can be applied to a lot of different things. And this is really trying to move back to the continuum of engagement, trying to move from just consultation, but how do we actually cooperate and collaborate to have more meaningful engagement? And so there has been this push for co-creation that you'll hear about. This slide is taken from the Accords Adult and Child Center for Outcome Research and Delivery Science, which is out of University of Colorado with Russ Glasgow. And they have a lot of great workshop materials and guidebooks available on their website. But the idea behind co-creation is that it is really working on that collaboration, that the patients and communities are important members of the actual design process and inform how things are going to be, and they co-create the materials together or interventions together. So you start with teams of clinicians, patients, and researchers that come together in workshops and testing sessions. Those share input and insights, and they work together and identify their own set of goals and kind of come up with a shared vision. From that, they collaborate to create those interventions and workflows, and then move forward into, as they're being implemented, the feedback goes to the team for improvement. And this would look different across the study phase. The exploration phase might be early engagement of the clinic team and patient partners through interviews or workshops. Qualitative methods have become very important in implementation science, and this is one way of increasing community engagement. Go do some qualitative research with the community you're interested in to identify and refine what the intervention you're trying to implement should be based on their partner perspectives. This can be often supported through internal pilot funding because you're really just trying to explore and identify the needs. This is often our pre-implementation evaluation of barriers, facilitators, needs, resources that we can use to inform. You move into the planning phase where we really are working together hand in hand to co-create things, and then move into an implementation and sustainment phase that has ongoing engagement, formal testing of the intervention or implementation strategy, and that's where you're going to need a lot more significant grant funding as you're moving into those implementation trials. So as I mentioned, the exploration really starts with interviews and identifying the functions to link to the core values. These can be done in focus groups, but it could also be interviews with key partners. And this is important at this point, is to also, during the interviews, is identify who should be at our co-creation. Who are the important stakeholders in our work? Not just input from the patients, but we want to look at the clinical teams that we're implementing in. Perhaps payers have an important role, perhaps hospital administrators, and really understanding who are the major players that need to be involved, as well as what are their goals and what can they do and contribute to really inform the actual planning and co-creation process. The planning phase is where the fun happens. When I've done this before, we do almost full day workshops where we bring everyone together as much as possible, and we really you work through initially our values worksheets, and identifying, from our interviews, these were the things that were identified as the core values and the goals. Does everyone agree? How are these putting? And that time really has that ability to make sure that we're building trust, that we're valuing the input of the community members, that their goals are just as important as maybe our academic goals and public health goals. This is where, I always say we like to go slow to go fast. We want to take the time to make sure everyone's voice and thoughts are being represented in our goals and core mission. And having that time in the workshop as a group can be really meaningful to really build that trust, develop that rapport, and make sure everyone feels heard and understood. From there, we take what are the needs and goals, and we develop what would the workflow look like. This is where it's really important to have all parts of the implementation team available. I do a lot of work in the ICU, and some of the interventions we do, the actual attending physician, their main role is just putting the orders, that the work and the caring is being done by respiratory therapists, nurse, advanced practice providers. And so they need to have input on what are the workflows. Many times my attendings are like, I really have no idea what goes into, putting a patient in prone positioning and implementing that. And so having those key members involved that can kind of inform the workflow can identify those key barriers and facilitators that might help and make sure that this strategy is going to be implemented. And this is where we can also identify adaptations. If we're implementing at multiple sites, having each site there to be able to say, that's not the way our clinic works. We are going to need a different workflow, or we're going to need to tailor it to this context in that way. And to see how much adaptation you can influence. Maybe there are some things you're not able to, but to really figure out how it can fit to those different settings that we're working in. From the workshops, we develop our implementation strategies, and we work towards getting the implementation started. But this is where the work goes. We really roll out all that planning and exploration to implement the intervention. We want ongoing engagement to identify the challenges as they come together. We work together to overcome those challenges. And then as we're getting near to sustainability, we need to work with our partners to find ways to frame the benefits, to talk about what did we learn and what was the benefits so that we can get ongoing support for sustainability. I work in the school systems about implementing asthma interventions. We did a lot of this work in developing and co-creating an asthma intervention that could be implemented in the schools by school health suites, teachers, family service coordinators. And as we were doing some interviews around the engagement and identifying challenges, one of the challenges we found was finding time to meet with the teachers for the asthma training. They've got so many things to do that finding, 3 to 4 hours to really learn about asthma and what it takes to manage it was very difficult. And we would get a lot of just pushback from the administrators saying, oh, we don't have time for that. We don't have time. This is really hard. But when we met with our teachers, they really talked to us about, we expected them to say, we're too busy. We don't have time. And actually, we got the opposite. They said, I really want this training. I have 10 children in my classroom with asthma. I worry that I need to be able to take care of them. And getting this training reduces my stress, reduces my worry, because I know what to do if those kids start having asthma symptoms. And so we got information on how we could frame the benefits. When we talked to the administrators, they were more willing to give us more time to do that training ongoing. And so really listening, they know what helps. And we will identify new benefits that we potentially would look at. Not only maybe we can improve asthma outcomes, but we can reduce teacher stress. That's really important too, and can be an important benefit as we look for sustainability. So I'm going to move forward into one of the examples that I've been involved in. for many years, and this is how we can implement better high quality clinical care for pain management in sickle cell disease. This was funded by PCORI initially as a comparative effectiveness trial, moved into a dissemination implementation project, and we also did receive an engagement award as well. So we've been kind of through their spectrum of funding. Pain and sickle cell is a really important clinical problem. They present with acute pain crises that require very rapid treatments with IV, often intravenous opioids, and in order to reduce the pain and improve outcomes. What we found was that pain delivery, pain management in the ED was fraught with barriers. The providers did not know how to care for these patients. There was long delays in care with patients sitting many hours waiting to be seen. And they were also dealing with a lot of stigma, being labeled as pain seeking or drug seeking or things like that, making it difficult for them to receive high quality care to manage their pain in a time of acute need. My colleague, Dr. Sophie Lanscron, who I've been working with, who's a hematologist, an adult hematologist that specializes in this, found and started working with at Hopkins locally, but really identified that the use of an outpatient infusion clinic could be helpful for managing those vaso-occlusive crises or pain crises. And this would be on an outpatient basis, but an urgent need that patients, when they're experiencing pain, could be seen, could be assessed and be provided treatment. And, and if needed, then they could determine, could they go home? Could they need follow-up care? Would they they would send them over to the ED to admit. The average length of stay for these visits is around 4 hours, as it requires the assessment, the delivery of the IV pain meds, reassessment, and making sure that they've experienced some symptom alleviation. But it can be a complex intervention. I always say this is a very different implementation project because we're not just asking providers to prescribe a different medication or implement a screening tool. We're actually really asking for a new service line delivery where we're looking at existing outpatient infusion centers and asking them to develop and implement a whole service delivery system to be able to see sickle cell patients on an urgent need, and that they would get evaluated and could go through assessment, triaged and evaluated, receive their pain medications, and then reevaluated to determine disposition. And so this can be pretty complicated and required a lot of uptake, a lot of work to support implementation. And as we were trying to talk about this, the first thing everybody said is, well, how do we know this is going to be better care than the ED? And so our first project with the PCORI was a comparative effectiveness trial. And it wasn't a trial, comparative effectiveness research. We were not able to randomize. We couldn't tell people they had to go to the ED or they had to go to the infusion center. They had to have the choice. But we did a matched control using, to be able to compare patients that were seen in the emergency room versus the infusion center. And we did this at 4 centers across the U.S. That had an associated emergency department. 2 of these centers had dedicated sickle cell infusion centers, meaning their infusion center only saw sickle cell patients. 2 were actually shared within hematology oncology, which is a unique model, but that we were able to get those hematology patients seen, in that center. Our data showed that we had about 444 participants enrolled, and then we compared for their acute pain crises, what their outcomes were from the EMR, whether they were seen in the infusion center or the ED. And it was an observational cohort, as I mentioned. And what we saw was there was a significant improvement in care delivery, with the time to first dose being 62 minutes in the infusion center compared to 132 minutes in the ED. We now have 60 minutes is our guideline to get first dose under 60 minutes. And so you can see this is not only clinically significant, statistically significant, but it's clinically significant. For a patient in acute pain to be able to get their medications almost an hour earlier has a real meaningful and has a really big impact on their overall care, quality of life and well-being. We also saw that patients seen in the infusion center were 4 times more likely to be discharged home compared to going to the hospital, which has a really big uh, impact on utilization, payers, as well as offloading our ED and inpatient beds, since they were able to get pain meds earlier, get managed, and be able to discharge home earlier. So as we wanted to implement this more broadly across the US, we did a lot of work on that planning, that exploratory phase, where we met with payers, we met with patients, we met with clinicians in different settings across the US. And we also met with community-based organizations. And these, I will say, are often patient-led, things like the Sickle Cell Disease of America. And we thought they were a really important partner for us because this intervention wasn't as easy as just getting the clinicians to prescribe. We really needed the hospital and the health systems to say they would be willing to support this service line, that they would dedicate nursing time, EMR time to be able to implement this, and see those patients in the infusion center. And so we needed advocates, and those community-based organizations are really our biggest advocates in sort of asking for support for these service. And so we've identified lots of barriers at the community, institution, and clinic level, as well within the provider and patients. And that all kind of that led to maybe difficulty implementing the infusion center. A lot of it were related to costs and reimbursement rates, and training and support for the clinics and providers in sickle cell and infusion center. And increasing awareness and patient trust that they would be seen and that they would receive just as high quality care at the infusion center versus the ED. So there was an acceptability and buy-in from the patients to come to the infusion center. From here, we developed what we call our toolkit, which is online, and it had information to address these barriers at each one of those levels. It had, for the clinics and providers, it had lots of training resources, it had EMR templates, it had clinic policies, things like that, that if you decided I want to create an infusion center for sickle cell, you could look on here. Even things like what list of medications should you put in your Pyxis for dispensing and making that easier are all available here. In addition, we also created, we needed to identify our partners to inform how we could actually get enough sites that increase the adoption and implementation. So we worked with the National Alliance of Sickle Cell Centers and the Maryland Sickle Cell Disease Association, that we held workshops at major conferences, like pre-conference workshops. And during this time, we would invite people who have a large sickle cell population to come learn more about infusion center care. And we would talk about our outcomes, we would share our policies, we would address concerns and barriers and make it an education and training opportunity. And we would then identify hospitals that might be willing to consider this. Many of them, it's because they have a large patient volume being seen in the ED that is very difficult to manage there. And so there was an interest in implementing a new program that would offload the ED and make sure that they were also getting better outcomes for their patients. In addition, we had community outreach and advocates. We would ask and we would talk to them about identifying a community advocate in their space to help, go to the hospital system and ask for help. We had to do this even in our own backyard here in Maryland. We're in Baltimore, but there's actually an area, what we call Prince George's County. It's about an hour and a half. It's south of DC. And it is predominantly Black population and the demographics, and it's our highest percentage in prevalence of sickle cell, and yet they had the poorest access to care. There wasn't really great services available in Washington, D.C., and although we border Washington, D.C., our Maryland Medicaid doesn't always allow us to be seen in any Washington, D.C. hospitals. So those patients in Prince George's County would have to drive an hour and a half to 2 hours to come up to Baltimore, depending on traffic, to be seen, really, which is really difficult during a time when they're having pain. And so we partnered with the Maryland Sickle Cell Disease Association president, and we gave him our data. We went over our program, and he worked with and met with the University of Maryland that had a hospital down there, and which we call the University of Maryland Capital Region, and that they were able to get funding set aside to start to implement a infusion center down there. And so really identifying your advocates is important, and having those principles of trust and partnership and finding out what we can do and where the needs are. So the CDC has put together a partnership or built, information on how what the importance of community partnerships and building bridges, and a lot of their recommendations for sickle cell match a lot of the principles I've already gone over. Identifying the key stakeholders, fostering the trust, regular meetings, continuous feedback, and then sharing, having a reciprocal sharing of information. That the study advisory board's insight will enhance our study relevance and making it more appropriate and tailored to the context. In addition, we can provide data and findings and results to help them increase advocacy for access to infusion center care. And so we became a true partnership where they were helping our studies, but we were also gaining them as advocates to increase adoption across the nation. This moved towards our implementation project, where we identified 9 sickle cell clinical sites in the US. Over the past 3 years, it involves over 3,000 patients that had, what we have data on is close to 4,000 infusion center visits compared to 1,300 ED visits. I will say the ED data was a randomly selected 1 day a week. We didn't want to burden the sites too much with having to look and extract so many ED data. So it included all the infusion center visits compared to 1 day a week for the ED. And we were looking at those 2 outcomes, time to first dose and disposition. And we allowed that adaptation. It could be shared or it could be a dedicated space for sickle cell, similar to our original study. During our co-creation workshops, where we met with the community stakeholders, the clinicians, and our patient representatives, we identified those barriers and identified the major strategies we can use to help overcome them. And we came up with 6 strategies that we implemented. We had our toolkit of resources and online documents. We had our telementoring sessions using ECHO, which is our once a month telementoring, where they received ongoing education and support on the use of infusion center cares. They can present clinical cases and get feedback from other experts in sickle cell, really creating a community of learning. We got funding from the HDISC to develop an advanced practice provider and nursing training program that actually now is a 1-year program, certificate program, where they go through an online program. They also have 2 weeks of shadowing with our master APP to really learn the clinical skills necessary for infusion center care. And they actually receive a certificate. It's in the process of being eligible for, and they get CMEs and everything. This was really important for our infusion center, for our clinical sites, because they had many of them used advanced practice providers in their infusion center care, but not all APPs receive enough training in sickle cell care. And so being able to have something that provided that dedicated training in sickle cell disease management was really critical to improving access in their infusion centers. And then we asked them to track their outcomes, and we provided monthly run charts with audit and feedback to see how they were doing. Are they meeting the national metrics of 60 minutes to time to first dose? What's their disposition? Are there things that might be impacting just using quality improvement methods? And then we had our network support for advocacy and engaging our community-based organizations, where we met quarterly with all of our community representatives from each of the 9 sites and really working on how we can continue for advocate across the implementation. And our goal was, with these strategies, we would implement the infusion center, whether expanding it or implementing new ones, and leading to improved sickle cell care. And, we found that this process really was necessary to be a partnership. As I mentioned, the community advocate was really critical to having and creating hospital administrator buy-in. We have said over and over to our community partners that the hospital, they don't want to listen. They have enough doctors knocking on their door asking for more money. But when a patient shows up and really states that they are not receiving the quality of care in their health system, they listen. And more than that, they also really don't want to hear that a peer institution is doing something better. And that is also the message that can be really delivered by a patient or community advocates. They are also critical for advocating for health policies, reimbursement rates, things like that are really critical for the ongoing support of this. And then we also noted that it was important as we did this to have a good partnership with our ED. In order to get the infusion centers to work, we needed the patients to be able to sometimes be transferred from the ED to the infusion center, or same likewise from the infusion center to the ED. The ED was very welcoming of this, that because this really helped decompress their patient volume. So the patients that were in need were able to be seen in the infusion center instead of in the ED. And they really liked what we developed is these individualized treatment plans where they knew what medications this patient should get to help manage their pain. They said one of the hardest things is not knowing the patients. They didn't know how much opioid medications they should be providing and what they wanted. And so having that available in the EMR and having that partnership made it a lot easier for them to treat the patients in the emergency department if needed. Because this infusion center were only open like Monday through Friday, 8 to 5, there's still a need for patients to be seen in the ED for those off hours, but they really appreciated having this partnership with infusion centers. So how did this, how did we do? Going back over to the PCORI foundational expectations. We really, I feel like, tried to make sure we met all of them. We had representative involvement. All of our sites were included, and they had to include a community representative and a patient representative in our community advisory board. Our community advisory board chair was our Maryland Sickle Cell Disease Association president, who was very active with us in this process. And so he was able to develop the agenda. He was able to lead the discussions and develop that trust among all the community members. It wasn't the academics running it. We were there, but it was his program and his really trying to work on that power imbalance. We had quarterly readings. They were involved in the proposal, and then they contributed throughout their entire study period. And as I mentioned earlier, this can be challenging when you are not sure you're going to get funding. And so what we did was, we made what different models I've done differently is if we can make this initially, sometimes we started as part of the clinical program. I have a colleague who works in sarcoidosis. She's the clinical director. She made the patient advisory board as part of her clinical program. And that has, then she was able to get some funding internally to support it as a patient event and a patient engagement. She worked with like the hospital health system marketing that maybe they would help support this. And then they were sort of, they would hear about the project and the proposal. And from there, she would identify maybe one or two of the patient advisors that would be interested in being meaningful and contributors to the proposal. And then have that conversation of like, we're going to put this application together, but it may not get funded. And, so it was sort of, she has this existing ongoing patient advisory board that supports her clinical program. And then she selects people who are really interested in that specific research proposal to work with her on the research, knowing that sometimes it doesn't always pan out. And having that engagement can be helpful. And then if she gets funding, she'll then create an actual study advisory board that nests within this patient larger program. We need to build capacity to work as a team. We've had, scheduled meetings at the clinic convenient times. Many times, as I said, our first couple are really setting values and goals, understanding their needs and wants. And really, one of the things that's come out of this is we've developed a best practices document that we're working to get published about what are the best practices in working with community advisory and community-based organizations and having them lead that project has been really meaningful because I know what I do, but having them tell me what they think is best or what was really helpful has been very impactful. And the things that I mentioned are exactly what they want. They want to be seen as a valued partnership. They want the data, but they want the data in a way that they can understand it. And they want to know what their role is and what their contributions are. So making it less advisory and consultative, but actually working together, collaborating and coming up with action steps and action items for both have been really helpful. We have dedicated funds within our grant to pay for them and budget for their time. Meaningful inclusion, where the chair is, as I mentioned, involved in all the meetings and sets the agenda. And we have ongoing evaluation. Each quarter when we meet, we'd ask about our study goals, how things are going, and how we can continue. As we are now wrapping up this project, we've shared our outcome data with them. They really expressed an interest on how do we get our results of the improved time to first dose and reducing our disposition and our discharge rates to the hospital. How do we get that to the payers so that there's continued support? And they're very, very motivated to continue in their advocacy for Medicaid policies to make sure that these infusion center cares will continue to be paid for. We've had success. All 9 sites established or expanded our infusion center. 4 of the 9 had a new center where 6 of the 9 expanded our staffing to increase. And we had 2 sites that added new capabilities, and they all used the resources. And we're now working with the National Alliance for Sickle Cell Care to scale this up nationally, having yearly conferences. And our toolkit has now been available for everyone nationally. And we have ongoing support for our training programs. So I'm going to end there to acknowledge all my collaborators over the years and patients and the funding that I've received that have supported this work, and I'll open up for questions. I appreciate your attention.
Wow, thank you so much. Michelle, this is incredible, actually. I mean, it's such an incredible story. I'm just was so happy sitting here just listening to everything you were saying and all the accomplishments that you've had. I mean, that's what a great example of something that started out as kind of a smaller scale. Let's study the outcomes of infusion center versus ED, and then and really realizing that one was better and trying to implement and doing it in such an amazing patient-centered way. I'm amazed by the number of stakeholders and that the different groups that were involved with this, and how much planning that took. And I know others may have comments and questions as well, but I'm going to ask one of your earlier slides, where you talked about CFR, where's the patient? I love that. I mean, that is really true. Where is the patient in CFR? We're talking about the processes and the care environments and the providers, and the individuals are really the people in the care environments in general, how we think of it. So including patients and stakeholders, the goal is to improve adoption. But I was curious, you gave some examples. I mean, I guess your main outcomes for this work are, to decrease the time to the first dose, and to, just have the appropriate site of care. Were there other patient focused outcomes that maybe informed how the intervention was going to be delivered? I mean, I'd love to hear more about not only improving adoption in the way that you had envisioned or the team had envisioned it, but were there some, patient contributions that made the delivering of the intervention different in any way?
No, that's a great question. And I did pass that. We did actually look at patient satisfaction. We had a patient satisfaction survey that they completed each time at the infusion center. In the original trial, we had it at the ED level as well. And it showed that patients really did appreciate the care that they received in the infusion center compared to the ED. And so that was an important, also meaningful patient outcome for us. And when we talk about adoption by the clinics and the health system to implement this program, but there's also adoption by the patients. They have a choice. When they're in pain, they could go to the ED or the infusion center, and that impacts our reach and the amount of time we're able to deliver it. And so we worked with the community-based organizations to, in some ways, I mean, we don't really market our healthcare, but in some ways it is a little bit of a marketing. And so talking to the patients about why they would want to be seen, come to the infusion center, call the infusion center first before the ED. We have a lot of patient education materials around that. And on our toolkit, we did have videos of patients whose testimonials about what it meant to get there. And, honestly, this wasn't too hard of a sell. If they're able to get their pain meds earlier and be seen by the same provider, they came back. They knew where it was. And so I think the important thing was delivering high quality care that the patients felt an impact in there. But we did include them in that, in sort of, as people have opened up a new center, how can we get patients to make sure that they know to come, to use the center, and what outcomes. In addition, we do, we've talked about really using the patients as the implementers and the advocates. And so there's been some training and engagement around that as well. So.
Great, thank you. Other questions? Because I have a whole list here, but I could.
I have a
If people do
question.
have questions, just real quick, Valerie, if people in our audience have questions, you may put that in the chat and we will address as they come up. Thank you. Go ahead, Val.
Yeah, Michelle, that was an amazing talk. It was so interesting. I have a question about like this work is engaging patients and community is very hard, and I think that does come across given everything you talked about, all the principles, all the steps, all the processes, the time. Um, I'm wondering if you can either talk about some of those challenges, either that you specifically experienced, maybe in that project, or you maybe just kind of know common challenges, and then how you address those. I'm thinking of one specifically, but please speak to any. But the time horizons of our projects are long, and patients or community members' lives may run on a different cadence, right? And so like one challenge I'm curious about, if you have any insight into speaking about, is like, how do you keep people engaged? What are those incentives? I hear, compensation, but what are other things to try to either keep them engaged, or maybe like kind of an infrastructure where you recognize there might be turnover, but you're prepared for that?
Yeah, I mean, that's an ongoing challenge. I do a lot of work in COPD, and they're older adults, and honestly, they just, their health deteriorates, that they're just not able to as well meaningfully engage sometimes, or they get a cancer diagnosis. We've had it all, or unfortunately even passing away. So one of the things we do is we do yearly, regularly, and I would say probably yearly, look at like, so-and-so hasn't been able to come very often. We're not going to take them off, but I think we need to add more. So we do ongoing addition into our study advisory, patient advisories. And we do keep an ear out, our clinicians, of like, if you have a patient that's asking you about what research you're doing or shows interest, this might be a really easy way to we're always open to new members. We don't make it a closed group. And so really always thinking about how can we ongoing, because I mean, sometimes people just, they have a chronic illness. They're going to be, their lives are going to be up and down. And so I think keeping ongoing engagement and adding new members is just necessary. We often think of like, we have our study team and they're going to be our study team, but that may not be always maybe possible. And so I think having an existing group that you're just kind of continually adding members to as they move in and out is okay and important. And I also think that having new input, new perspectives makes it more interesting. It does, like, by the time we get through some of these meetings, like 5 years down the road, there's not much more to say. So having new people come in and share those experiences and new ideas can be also helpful. So I just feel like we just need to keep adding. I always do say, as we're putting together one, I'm like, add more patients than you think you need, because not all of them will show up. So overdo it, over increase. And, it might, it usually kind of works out because they're not able to always come to all the meetings.
Thanks. Yeah.
I do see one question in the chat about working with children and youth. I'll be honest, most of my work in asthma have been with really young children, preschool and elementary school age, so they're not as actively involved for that. So but I do know some of my colleagues who've done work with more adolescents and things. I think it's important to have, if you are doing that, the ones I've seen the most successful is to have like a parent stakeholder group and then have a separate adolescent group. You do want to keep them almost separate so that the adolescents can speak separately, they can have independence and autonomy. I feel like oftentimes when I've seen adolescents and parents in the same group, even if we do clinical visits, the adolescents kind of take a step back. But because of that, you're going to have twice the amount of work. You're going to have the parent group so that there's consenting and they know and they're on board. They know what they work with, as well as the adolescents. Sometimes some of my colleagues have done them concurrently. If you had, a co-investigator that can help, so that they're, if you're doing them in person. Most of ours now are all Zoom, but at least then that can kind of happen. It is definitely a lot. It is worth it, but it can be more work as we're engaging both groups.
Oh my gosh. Well, we're at 1 o'clock, but the one thing that I thought was amazing, well, not the one thing, but one thing I thought that was amazing was that you now have this like APP training program. And so like this starts out as a research project, but then it kind of morphs into this huge care delivery change. And now you are training professionals to have more skills and empower them. I mean, I think it's amazing, actually.
That is really more my colleague who is she sees it like Dr. Lance Cron, who sees this as important. And that really became a major barrier. And as we developed it and she was doing it on her own, she's like, can I get grant funding for this? And so I think we often do a lot of stuff that we're not aware that we can, make it more formal. And the more she got grant funding, she made it an actual certificate, the more uptake. And so I do think, figuring out ways that we can, the work that we're doing in implementation science, how can we get other additional supports, not just the research, but to make it sustainable is important. And may not be for the actual service, but there may be components of a training program, a CME program that can help support this work. And it's been very successful in our project with 9. All 9 had an APP go through, 7 completed, and many, because of turnover, ongoing, because they lose an APP, they need to hire. As a clinician, it's so easy to be able to tell your APP, oh, you got to go do this, and you feel confident in the training that they're going to get.
Yeah. Well, that's incredible. Thank you so much. We've really loved having you, and
Thank you. And thanks to all my colleagues who've also supported this work. It definitely was a team sport.
Of course. Yeah. Well, thank you for everything.
Okay, sounds good. Have a good one. Nice to
Take care.